Yeah, thank you, Aldo. I guess I'm on now. I cannot see you. I cannot see myself anymore. I can only see my presentation, but I will still do my best to make it as real as possible. I try to get as near to Canada as I was able to. So I'm in Buffalo, New York now. They told me that Buffalonians consider Canada not north, but west, which is true in our case. So something I learned already. And I'm very happy to be able to give this talk. I'm very thankful that I was invited. I'm thankful to Myeloma Canada and especially also the amazing technical team who made it possible that I can sit in my apartment and give this talk here. I have my coffee next to me. It's very convenient, I have to say, but I know you see me, so I will try not to embarrass myself too much. So talking about imaging, if you don't hear anything, please let me know, or if something is too fast, too loud, too silent, please just let me know. Imaging myeloma is my topic of research for nearly 20 years now. I'm very interested in that. And in the beginning, no one was really caring about that when I wrote articles or when I wrote abstracts for conferences. No one really thought it's interesting. But nowadays, people learn that it's really a lot we can learn from imaging. And there are several reasons for that. To start, it does not start yet, just a moment. Yeah. To start, it's important to differentiate what we can see in imaging. As I guess most of you know, and as I know most of you have experienced, one of the major symptoms of multiple myeloma is the bone disease. The overactivation of bone resorbing cells, the so-called osteoclasts, which cause osteoporosis or osteolytic lesions. That's something where imaging was always a part of diagnostics. But myeloma itself, the plasma cells, the malignant cells themselves are living in the bone marrow. The bone marrow is the organ of the body where blood is produced. And the bone marrow is within the bones. In adults, it's mostly the spine and the pelvis, to a certain degree also the sternum and the skull. But we have really to differentiate between bone and bone marrow. This is what I want to show you with this cartoon, because the disease itself is going on in the bone marrow, which is different from the bone, where usually a lot of symptoms come from. And oftentimes those symptoms are really the symptoms that lead to the first diagnosis of the disease. So we have several techniques we can use. I guess all of you know conventional skeletal survey X-ray, where we can image all parts of the skeleton. We have a further development of that, while in X-ray we have the beam, the radiation beam, going through the body in one direction from one area to from one direction into the other, and is detected on the other side. In CT, the beam goes around the body in circles to see, kind of have an image from every angle of the body. Magnetic resonance imaging is based on the water content, and as you know, really a high percentage of our body consists of water, and this distribution, or where the water is, where it's more water or more fat, that's the opposite for MRI. Water and fat distribution are the information that provide the MRI image. And positron emission tomography works in a way that you give a radioactive agent into the veins, and then you look. This is attached to a sugar, and malignant cells and also inflammatory cells have the ability or the need of a lot of energy, so they consume sugar. And so they take up this sugar, this radioactive sugar, and you can measure with the camera where this sugar is located and have this information where those malignant cells are. So those are the techniques we have available. What do we see in those techniques? For X-ray and CT, they are the best for the bone disease, to see what is going on in the bone. Is there bone destruction? Is there osteoporosis, or are there osteolysis? The bone marrow can be detected to a certain degree by CT. I will show you what I mean with that. Also by MRI and also by PET. PET is usually combined with CT because the PET itself is rather blurry, as you can see here. This is a part of PET, and we usually put a CT under that to locate where those changes are, where those light or those reddish parts of the body are. I mean, the brain usually also needs a lot of sugar, so you can see the brain is also lighting up in the PET. So we can see bone, we can see bone marrow, but we can also get functional information to a certain degree in PET, because we see where the metabolism is taking place, where there's a lot of need for sugar, and also functional magnetic resonance imaging techniques, and I will show you what I mean by that, can show more information than just the morphological changes in the bone marrow, but beyond that, we can also see some changes like microcirculation, if there's a lot of blood vessels in the bone marrow, for example. This is what we can learn from imaging. So bone marrow, and further information, not restricted to the morphology, but also to functional information. Starting with the bone imaging. This is clinically the most important one. Skeletal survey has some advantages. It's very widely available. I gave this talk in several countries in Europe and in the US, and already also in Canada. And I know that all over the world, X-ray is very easily to access. It is the basis for our classification, the Jury-Selman staging system, which is kind of old now, but still some people use it, and the so-called CREB criteria. I guess you have heard about them. The hypercalcemia, renal insufficiency, anemia, and the bone disease, which is the B of the CREB criteria. It has a rather low radiation dose, especially nowadays. In the early days, we had to blacken films, actually. There we needed a lot of radiation, but nowadays these are very sensitive detectors, so we don't need too much radiation. A disadvantage is the very low sensitivity, and I will show you why I say that. And it's a rather long examination time. If you had a skeletal survey, you know that it's rather uncomfortable. It takes some time until you have your legs and your arms and whatever put to these detectors. And it's not really comfortable, especially compared to CT, and I will show you why I say that. This is a very old study, as you can see here. It was already in 1967, and they had the idea to detect the sensibility of conventional X-ray for detecting of osteolytic lesions, which can also occur in other cancers. And so they took the spine of a corpse and drilled holes in the vertebral bodies. And as you can see here, they drilled bigger and smaller holes, and they found that you have to destroy 30 to up to 70% of bone until you see a change in the conventional X-ray. And in my point of view, and I guess most of you agree with that, this is really too late. We cannot wait until 50 to 70% of bone is destroyed until we see something in imaging. That's the reason why I am a big fan of computed tomography, with a much higher sensitivity. The advantage is it has a superior detection rate for especially the bone defects. This is mostly caused by the fact that the CT beam goes around the body, and that you see it from every angle, and this gives a much higher sensitivity. And we, as you might expect, it has a higher radiation dose, but because the bone itself is very, very dense, and the density has an effect on the weakening of the beam, of the radiation beam. And so therefore, because the bone is very dense, we don't need a very high dose for CT. And so there are low dose protocols. And when I came to the US, in Germany, we did it for a long time now. In the US, it's not really common. I'm not sure how it is in Canada. But I try to convince colleagues really to use CT, because with a much better sensitivity, with a not really much higher radiation dose, we get much more information, especially also 3D information, meaning that we can see where in a single bone where the osteolysis is. If you just do an X-ray, you have just this one plane, or you might have two planes to see where the osteolysis is. In CT, you have a much better resolution where the osteolysis really takes place. And this is very important also for stability assessment. It's very convenient for the patient. It takes about 3 to 5 minutes. You just lie flat on your back and go into the scanner and come out again. You don't even need contrast agent. So that's, I think, very convenient, especially compared to the skeletal survey. It has therefore been, because of the higher sensitivity and of the better convenience, and because we really have this data now, has been included in the new definition of multiple myeloma. When we started to do that in Heidelberg, Germany, where I'm coming from, a lot of colleagues said, are we detecting, maybe, do we detect the bone disease too early? But I really had to challenge them, because I mean, there is no too early. And I heard some remarks about the early detection. I think it's very important. We should not wait until there is really a lot going on. If we have the information and if we have the possibility to use these higher sensitive techniques, I think we should really do that. It is also prognostic significance, especially when you detect small lesions. You see, if CT is negative, I will show you a table for that later. You can see that if X-ray is negative but CT is positive, then those patients really go on into symptomatic disease, really with bone disease very early. And so another reason, I think, not to wait too long. Disadvantage, it has a bit, as I mentioned, higher radiation dose, and with those low dose techniques we found that it's about 2 times the skeletal survey. With the right scanner, it doesn't have to be a very fancy new one. The right sequence in a computed tomography scanner will give us about double the radiation dose, but in my experience, and this is really true, we don't need as many examinations as we have done before. And maybe in the end we come up with a lower radiation dose overall, because a skeletal survey I would do every year because the sensitivity is so low, I don't want to miss something. With the CT, we are very comfortable knowing what's going on in the bones. And if a patient is in remission for a long time, we don't have to repeat the imaging if there are no symptoms and no signs for progression. So in the end, maybe at the end of the day, we might even save radiation dose. This is what this looks like. On the left, you can see this kind of flying through the body. You can see the spine here, you can see the shoulder blades, the arms. This is the lung. We get additional information. We can also see the lung, here the spine, very important, the pelvis, and here the lower extremities. So this is very convenient, and the computer can calculate that, this 3D information, and you can see here as we have this sagittal view, as we call it. We have done a project to convince our colleagues that CT is better than X-ray, and we compared patients can be CT negative, CT positive, skeletal survey, conventional skeletal survey negative and positive, and you can see here 25% of patients which were negative in skeletal survey, conventional X-ray, were positive in CT. So 25% of patients would have been missed. There were also, surprisingly, some patients positive in a skeletal survey compared to CT. This was mostly caused by the fact that in the early days, we did the CT with the arms over the head, or above the head. And nowadays, we put them next to the torso to have them in the field of view. We just missed it because it was not in the field of view. So nowadays, we know how to deal with it. And CT is really much better than X-ray. That's the message here. Where are those osteolysis? In the same study, we looked where we find the most osteolysis. We have some in the skull, we have some in the humeri, some in other areas. But in green, you can see the spine and the pelvis are really those areas where we have most of the changes, most of the osteolytic lesions. This is important because sometimes it's not possible to do a whole body CT, but if you can do a CT of the spine and the pelvis, you get really a lot of good information there, and this is the most important part of the body. But of course, if you have access to a whole body CT, it's even better, and also in the lower extremities. I have learned that really near to the real distal extremities, there are very, very few osteolytic lesions. I have seen that, but it's very rare, and so if they are not in the image, it's not a big problem usually. there's this information, those curves called Kaplan-Meier curves, they show every movement down of the curve says one patient was progressing. Those were all smoldering, so early stage myeloma patients. And you can see if they were CT negative, they had a rather slow progression into symptomatic disease, and those with really changes in the CT. At that time, patients with smoldering myeloma were not treated even if they had changes in CT. And you can see here they had a really early progression those months. So after 2 years, nearly every patient with a positivity in CT was progressing into symptomatic disease. So that I think it's really relevant to know that, and in my point of view, really treat those patients earlier. I mentioned that the bone is one part we can image, but we can also image the bone marrow where the actual disease takes place. And I think, why should we wait until we see changes in the bone when we can look in the bone marrow? So you see, to see this is okay for a mole, but not okay for us and for hematologists and radiologists. Advantage of MRI. It shows the infiltration of the bone marrow before the actual bone has been destroyed. I will show you images for that, and I think this is really, really important and has been recognized by the colleagues. It has a very high resolution also for the soft tissue, but especially again for the bone marrow, because plasma cells usually are very dependent on their bone marrow, so-called microenvironment. They are nurtured by the cells around them, and they live in their so-called bone marrow niche. And this is very important to look into this area. It helps to, and I also show you images for that, to differentiate between benign and malignant fractures, meaning that, for example, if a person has an MGUS, maybe an older lady, and she has also an osteoporosis, oftentimes we are not sure, is it really a myeloma with this M protein, this monoclonal protein, and a destruction of the bone caused by the myeloma, or is it just a coincidence that she has an osteoporosis and an MGUS, which are both diagnoses that are rather common in the elderly population. And with the MRI especially, we can differentiate if where the destruction of the bone took place, if there were a lot of cells, which would rather be a sign that there are a lot of plasma cells, and so myeloma, or if there are very few cells or little cells, which is usually in us, in elderly persons, and I even have to say in my age, the content of the bone marrow becomes more and more fatty. And as I mentioned, MRI is very good in differentiating between fat and cells. And so high cell content, rather myeloma, high fat content, rather benign osteoporosis, which can occur especially in postmenopausal women, but also in men. It has been included into the definition of multiple myeloma. I will show you later what I mean with that. And it has, of course, also disadvantages as every technique. It is inferior to CT for the detection now of the bone, the mineralized bone, the skeleton. The problem is the bone does not have really much water in it. So where there is nothing in MRI, there's usually bone, because it's just a black line. So it's very difficult to differentiate. And you can see that here in this area, this whitish or light gray scale, that's the fatty bone marrow in the long bones, for example. But the bone itself is not really visible in MRI. Some patients cannot have an MRI because it's a very high magnetic field, no radiation, but high magnetic field. And so some metallic implants would move if you put a patient with them into the scanner. We don't know if residual lesions after therapy, I will also show you images for that later, have a relevance for the patient. Should we go on treating those patients or should we not? So this is one disadvantage, but I think it's not a very big one. Is it relevant to do a spinal MRI or a whole body MRI? We compared spinal and whole body MRI in 100 patients, and we found that, as I mentioned earlier, the most disease burden is usually in the spine and the pelvis. So a lot of centers only have access to a spine and pelvis MRI, and have to say you will cover 90% of patients. We found that, as you can see here, this 10% were patients who had only changes outside of spine and pelvis. So we missed something, but it's not that important, especially if we have another technique showing the whole body. Excuse me. So yeah, whole body MRI is obviously better, but the extent of what it's better, it's not that much. It's about 10% that we might miss. Coming to positron emission tomography, advantage, it shows the metabolism. This is important because it correlates to a certain degree to the disease activity and has also a prognostic significance. So a high uptake of this sugar that I mentioned, this radioactive sugar, is a sign that the disease is rather aggressive. It doesn't say that we cannot treat it or that's a huge problem, but we know that if there's a lot going on in PET-CT, we know that we have to treat really significantly, and this is something we can learn from PET-CT. Disadvantage, it can have false positive results. I already mentioned that also inflammation, which is also not uncommon in myeloma, can cause changes that are not being able to differentiate to be differentiated in PET-CT, at least not with the so-called tracers, which are the contrast agents we use in PET-CT. We use nowadays. There are developments to be more specific for myeloma, but this is at the moment rather research. It's not in the clinical routine there yet, but we are developing better tracers to differentiate between inflammation and malignant infiltrations or myeloma infiltration. It's rather costly, but that's a problem, hopefully, that politicians should deal with. Sometimes not, but yeah, they should. And it has a bit of a higher radiation dose because it combines the CT part for the localization and the nuclear tracer, this radioactive tracer, which of course adds some to the radiation dose. But again, this is a technique that gives us a very, very high content of information, and we don't have to do it that often. So we do it less often and save patients from radiation dose with that. It's just something to keep in mind. It is difficult to see the diffuse infiltration, but I will show you what I mean with diffuse infiltration. This is just a mention here. If you compare the techniques, usually I'm asked, yeah, now what should I do? I can do a CT, I can do an MRI, I can do a PET-CT or even X-ray. So what are the differences? You can see here on the arrows. I hope it can be seen. Sometimes it's not easy with a projector, but here is a darker area. This is a so-called focal lesion. And we actually in Heidelberg, we did a study, we put needles in that, CT guided, did a biopsy, and in all but one, it was 65 patients, and in all but one patient, we found plasma cells in there. So those lesions are containing plasma cells. There can be accumulations of plasma cells. That you can see here, same patient, same time point. This is the CT part showing us the bone here, and there's no change. There's no osteolytic lesion. So it is important to know that MRI changes do not always have to go along with an osteolytic lesion. They can, but they don't have to. So MRI, as I said, shows the change in the bone marrow before the bone is actually destroyed. When we compare PET with CT, we usually have both because it's a PET-CT, but if it was compared, and colleagues from Italy did a study and looked into smoldering myeloma patients again, so defined by not having osteolytic lesions. So the CT was by definition negative, and they found that some patients still have so-called focal lesions, the same as you have seen in MRI. They can also have these accumulations without destruction of the bone. So PET and MRI show changes before the bone has been destroyed. Comparing PET-CT with MRI, for the focal lesions, both have the same sensitivity. If it's positive in PET, usually it's also positive in MRI and vice versa. For the diffuse infiltration, again, I will mention or explain that later. For the diffuse infiltration part, the MRI is better than the PET-CT. You can see here, this is when we do everything in the patient. This is a PET-CT with here an area of increased so-called tracer uptake, meaning that there are a lot of plasma cells. Here it's the same in the so-called T1 MRI. Here, that's the change. And here in the so-called T2 MRI, here, the focal lesion. And this is a new technique. I will briefly talk about that later. It's an MRI technique without contrast agent, without radiation, that also shows with a high contrast the changes in the bone marrow. So these are the so-called focal lesions in different imaging techniques. Comparing the techniques, to summarize this part of my talk, the technique skeletal survey has a low radiation dose, is okay to detect bone changes, but as I mentioned, 30 to 50 to 70% of bone has to be destroyed. We don't see much of the bone marrow or the soft tissue, and vessel density is more for research, but in the bone marrow, we have no information on that. A little bit higher radiation dose, as I said, about double of the conventional survey. Skeletal survey has the low dose CT. It shows the bone with the highest sensitivity. It's the best technique for that. It shows in part the tumor burden, nothing about functional markers, and it's really fast. PET-CT combines PET and CT, gives us, so by the CT part, gives us good information on the bone changes, but also gives us information on tumor burden and also on metabolism. It's rather long because you have to wait until the tracer has been distributed through the body. Whole body MRI has no radiation dose at all, doesn't show the bone too well, but shows very well the tumor burden, the infiltration of the bone marrow, and with functional techniques we can also add here information on the functional or the pathophysiological changes in the bone marrow. I mentioned several times the focal lesions and the osteolytic lesions, and this is a really, we know that for several time, maybe at that time they didn't know that, but they found skeletons with osteolytic lesions, so this is a really well-known change. Actually, they thought that those skeletons might have had multiple myeloma. So in MRI, we can see that we have those focal accumulations I showed you several times now, but some patients also have so-called diffuse infiltration. You can see here, this is a normal bone marrow with a fat content, which in this case, you can see here, that's subcutaneous fat, is rather light gray scale. But if you have those changes, it's darker, so-called hypointense in T1 weighted image. And you can see here the whole vertebral body is darker. So this shows that the infiltration really is in the whole vertebral body, not in this isolated focal lesion. I looked into literature some time ago, and I found that you can have everything. You can have a focal infiltration, about 30% of patients. We can have, you can have, I just got the information that I have 20 minutes left. So I will keep up my, my talk. So diffuse infiltration also in about 30%, minimal infiltration, meaning a bone marrow that looks rather normal, also in 20% of patients, even though those patients have multiple myeloma. And a mix of focal and diffuse infiltration is also in about 20%. We looked into the bone marrow and compared the MRI findings, meaning the diffuse and the focal part, with what we found in the histology when we did a bone marrow biopsy of the pelvis, and we compared that, and actually we found a correlation. Patients who had focal lesions in the bone marrow in the MRI also had a rather nodular infiltration. Those red cells are the bone, the plasma cells infiltrating the bone marrow. And if a patient had a diffuse infiltration, this darker grayscale, as I mentioned, this homogeneous infiltration, they also had in this case, packed bone marrow with a diffuse infiltration of plasma cells. So there seems to be some biology behind that. We do not know yet if this is really relevant for the patients, but we know that there are different growth patterns. We don't know why.